OCD: Background, Solutions, and Symptoms for Patients. Written by Sid Van Roy. Narrated by Doug Green. Chapter 1. An Intro to Obsessive-Compulsive Disorder. Obsessive-compulsive disorder is generally regarded as a neurotic disorder like phobias and anxiety states. Other terms used for this disorder include obsessive or obsessional compulsive neurosis and obsessive or obsessional compulsive illness, or simply obsessive or obsessional disorder or compulsive disorder. Those with this problem can suffer significant distress and often feel that they are defenseless victims. Though unstable disorders are normally considered to be less handicapping and disabling than psychotic illnesses like schizophrenia, extreme obsessive-compulsive disorder sometimes causes significant incapacitation and dramatically affects individuals' lives. Maybe a quick note is needed about the terms unstable disorder and psychotic disorder. Broadly speaking, neurotic conditions or neuroses are reasonably small psychiatric diseases. The unstable patient knows that he has an issue, that is, he has an insight. His contact with the outside world is relatively undamaged. On the other hand, psychotic conditions, or psychoses, are more serious mental disorders. The psychotic patient could have no insight that something is wrong with him, and his contact with the outside world might be significantly impaired. In the current psychiatric thinking patterns, obsessive-compulsive disorder is categorized as an anxiety disorder. Other anxiety disorders include phobias, panic disorder, and generalized anxiety. They all share anxiety as a fundamental function, and there is an overlap of symptoms amongst them. What is meant when a person is referred to as having an obsessive-compulsive disorder? The person displays and/or suffers either fixations or compulsions or both, to a degree that impacts his daily functioning or triggers him distress. Psychiatric analysis of the condition is generally made on this basis. This is shown in the generally agreed diagnostic criteria. 1. The person must have either obsessions or compulsions or both. A. Obsessions are persistent ideas, thoughts, images, or impulses that horn in awareness and are experienced as ridiculous or repugnant. They form against someone's will, and the person tries to withstand them or get rid of them. The person recognizes that they are his own ideas, and so on. B. The compulsions are recurring, purposeful forms of behavior that are carried out because of a strong feeling of compulsion to do so, and are normally performed according to certain rules or in a stereotyped style. The behavior is not an end in itself, but is focused on producing or stopping some event or circumstance. Nevertheless, the activity isn't connected in a sensible way with what it is aimed to produce or stop, or it is plainly excessive. The person generally recognizes the senselessness of the behavior and does not get any pleasure from carrying out the activity, though it offers relief from tension. 2. They are not as a result of another disorder, like schizophrenia, sadness, or organic mental illness. 3. The fixations and/or compulsions cause distress to the person and/or interfere with his life and activities. Chapter 2. The nature of obsessions. Actually, an obsession is an unwanted, invasive, persistent idea, image, or impulse. Obsessions are not willingly produced, but are experienced as events that attack a person's consciousness. They can be stressing, repugnant, blasphemous, obscene, ridiculous, or all of these. The person neither wants nor invites them. Instead, he typically resists them and tries to get rid of them. A fixation is a passive experience. It happens to the person. He may be participated in some activity, like reading a book or driving a vehicle, when the fixation horns in his awareness. It interrupts his normal thinking and behavior. Some examples of obsessions are as follows. 1. A young woman had the recurrent invasive idea that her husband would die in a car crash. She also had vivid visual images accompanying this idea. She would see the scene of the mishap, the two automobiles, the broken glass, the blood, and the hurt. 2. A young woman had the persistent invasive idea that she was contaminated by dirt and germs from complete strangers. 3. A guy had the reoccurring intrusive doubt that he could have knocked down someone crossing the road. 4. A young married woman had the frequent invasive impulse to strangle children and domestic animals. This would be followed by the thought or doubt that she might actually have done this. 5. A young man had the persistent invasive idea that Jesus was a jerk. He also felt an impulse to yell this out during prayer or a church service. 6. A boy had reoccurring intrusive pictures of himself violently assaulting with an axe his older parents. He also had the idea that he may actually commit this act. That experience included images of the victims, of blood flowing, and of injuries triggered. 7. A girl had the recurrent invasive impulse to harm herself by burning her eyes with a lighted cigarette. This was accompanied by visual images of the act. 8. A middle-aged man had the recurrent idea that he had cancer or would get cancer. 10. A 14-year-old girl had the persistent impulse to blurt out profanities in public. She also had the idea that she may actually do or have done this. Those examples show the highlights of a fascination. It horns in consciousness as an unwanted outsider. It could take the form of a thought, an image, an impulse, or a combination of these. Fixations in the form of ideas are far more common than those in the shape of impulses or images. When the fixation happens, the person typically resists it and tries to dismiss it. If he succeeds in dismissing it, it may well come back within a brief period of time. Some clients report that their obsessions are with them the majority of their waking hours, regardless of desperate battles to get rid of them. The effort involved in trying to suppress fixations can be tiring, even though the struggle isn't evident to good friends or loved ones. The patient doesn't regard the obsessional idea, image, or impulse as something stemming from outside. He recognizes and acknowledges that it is his own ideas. This is an important function, as in certain mental disorders, clients could experience thoughts having been taken into their heads by outside agents. Obsessions aren't experienced in this manner. It should also be noted that the meaning of the term obsession in the context of obsessive-compulsive disorder is very different from how the word is often used in day-to-day language. We typically hear someone being described as obsessed with his job, and expressions such as, "he is obsessed with her," "football is an obsession for him," etc. What is meant in such circumstances is that the person in question has an unusually great interest in something or somebody, so that every little thing else pales into insignificance. However, such an attachment, interest, or preoccupation is not seen by him as undesirable or unacceptable, and there's no resistance or any effort to dismiss it. Nor is it something that keeps intruding episodically into the person's mind. This is extremely different from the way the term fixation is used in reference to obsessive-compulsive disorder. Both senses relate to the meaning of the Latin verb obsidere, to besiege, from which the word fascination is obtained. What are fixations about? What are the contents of obsessions? There are some very common themes: contamination and dirt, disease and illness, death, violence and aggressiveness, harm and danger, and ethical and spiritual topics feature plainly among them. There are also sex-related obsessions and, less commonly, entirely ridiculous or insignificant ones. An example of one of the latter came from a man who experienced the frequent intrusive thought, "these boys when they were young." Woman had invasive visual pictures of asymmetrical objects and patterns she had seen, which would consistently come to her. In some cases, the fascination includes a doubting thought, which can apply to most things that the person does. Here is an example. A young woman complained that any time she performed any action, she would immediately be attacked by the idea, "Did I do it right?" or "Have I done the right thing?" Chapter 3. Compulsions. A compulsion is a repetitive and apparently purposeful conduct that's performed according to certain guidelines or in a stereotyped fashion. It might be entirely inappropriate or, more often, partially acceptable. The behavior is not an end in itself, but is generally intended to produce or to prevent some event or circumstance. Still, the activity isn't linked in a sensible or reasonable way with what it is meant to achieve. For instance, touching a relative's photograph a certain number of times, so as to ensure that no damage comes to the relative. Or it may be plainly excessive, such as cleaning hands for half an hour at a time to get rid of germs. There are also instances where the person takes part in the compulsive act simply to fend off great anxiety, and even panic. The act is preceded or joined by a sense of subjective compulsion. That is, the person feels a strong urge to take part in the behavior. Generally, there is a desire to resist. The person acknowledges the senselessness or irrationality of the behavior and doesn't derive any satisfaction from carrying it out, though it provides a release of stress or a feeling of relief in the short term. Some examples of those typical compulsions are as follows. 1. A girl repeatedly and extensively washed her hands to get rid of contamination by germs. The washing was done in a fancy routine, 6 times without soap and 6 times with soap on each occasion. 2. A young man checked door handles, gas taps, and electrical switches each time he passed by them. 3. A 15-year-old girl cleaned and washed the area around her bed, which includes the wall, each night before going to bed to rid it of germs and dirt. 4. A man opened letters he had written and sealed to make sure that he had written the correct things. Therefore, he would rip open the envelope, reread the letter, and put it into a new one several times before posting it. 5. Lady in her 40s complained that every time she went into a room, she had to touch the 4 corners of it, beginning with the left. 6. A boy had the strong urge to touch with the left hand anything he had touched with the right hand, and vice versa. 7. A young man had the compulsive urge to empty his bladder before each meal. Even if he had urinated a short while before, he would go and clear his bladder right before sitting down to a meal. He felt that otherwise he wouldn't have the ability to enjoy his meal. 8. A boy had the compulsion to look back over his shoulder at any structure that he was leaving. He would first look back over his left shoulder, then over his right, and then again over the left. 9. A girl had the compulsion to wipe with a damp fabric all tables and worktops, sometimes each time that she was to use them. She did this to get rid of what she called undetectable food particles. 10. A 35-year-old wife had the urge to wash and sanitize herself and her outfits out of fear of contracting cancer. She spent many hours each day doing this. The key function of all these examples is that the person feels a strong desire, a compulsive desire, to engage in a certain behavior, which he performs regardless of resistance and regardless of recognizing that it is irrational, or at least extreme. Covert compulsions. All the examples pointed out above are of obvious compulsive behavior, that is, conduct including physical actions, but some compulsions are concealed or mental. Sadly, a lot of writers on obsessive-compulsive disorder and lots of medical professionals, psychologists, and psychiatrists tend to assume that compulsions are always overt behavior. They consider fixations to be mental events and compulsions to be overt motor events. That division is inaccurate. It's certainly true that fixations are psychological events, but not all compulsions are motor behavior. Many clients have concealed or psychological compulsions, which have all of the highlights of obvious compulsions and such. Here are some examples. 1. A man had the compulsive urge to say calmly a particular string of words whenever he heard or read of any catastrophe or mishap. 2. A middle-aged woman who was distressed by the intensive recurring appearance in her consciousness of obscene words carried out a compulsive routine each time this happened. This included changing these words into comparable, acceptable ones. For example, well for hell, and saying them quietly 4 times. 3. A middle-aged man had the urge to imagine everything that was said in discussion to him and what he was going to say in reply. He would not reply until he had acquired these visual images. 4. Lady who was tormented by intrusive repetitions of bloody pictures of her relations and friends felt forced to reform those images with the people concerned in good health. 5. A young woman became really worried if she set her eyes on black items specifically before going to sleep. When this happened, she had the obsessional idea that it would trigger her to go blind or cause some other catastrophe. So, every time she experienced this, she felt compelled to imagine an item of a much different color, specifically white, as a way of preventing these ill effects. These examples should make it clear that compulsions aren't exclusively motor behavior but can be psychological acts as well. Covert compulsions are also described as cognitive rituals or cognitive compulsions. The active nature of compulsions. A feature of compulsions that needs to be worried here is that an obsession is actively brought about by the patient. He is not happy about doing it, but it is essentially his voluntary action, performed because of his compulsive desire and not an automated behavior. Therefore, it is different from tics and muscle spasms that are typically found in some people, specifically children, which are basically uncontrolled motor responses. Those aren't actively produced by the patient, making them different from compulsions. Resistance fixations and compulsions are usually resisted. At one time, it was considered by many specialists that resistance was an important feature of obsessive-compulsive disorder. Still, we now know that this is not the case. Although in the huge majority of cases, the person does resist the fascination or the compulsive urge, there are many exceptions, specifically with regard to compulsions. It appears that in the early stages of the disorder, a patient withstands his compulsive urges strenuously, but after repeated failures over a period of time, he might start to show much less resistance. Patients with chronic obsessive-compulsive problems could experience little or no resistance to the fixations or the urges. Different, a determinant of the word compulsion. Just like the term fixation, our use of the term compulsion here is different from and more specific than the way it is used in everyday language. We usually hear people talking about compulsive lying, compulsive eating, compulsive gambling, and so on. Those kinds of conduct are different from the types of compulsions that we are concerned with here. As noted above, compulsions are acts which are the result of a desire that the person normally tries to resist, and which are carried out unwillingly. They are viewed as basically illogical or ridiculous, and give no satisfaction or fulfillment. Forms of conduct like compulsive betting do not show these features, although they are issues in their own right. They aren't part of obsessive-compulsive disorder. At times, the term compulsive is used for behavior like recurrent nail-biting, thumb-sucking, and hair-pulling. Those are routines, and the person generally participates in them, at least part of the time, without being aware of them. They lack the characteristic features of the compulsion in obsessive-compulsive disorder, like purposefulness and meaningfulness. True compulsions are carried out to achieve some aim. Conduct like nail-biting, hair-pulling, and so on is not. Nor do they provoke a feeling of resistance. Those types of behavior are best viewed as habits, rather than true compulsions, as their resemblance to the latter is superficial. Chapter 4. Biological Causes of OCD. The fact that OCD patients react well to specific medications affecting the neurotransmitter serotonin explains that the disorder has a neurobiological basis. Coexisting conditions like attention deficit disorder or autism can make OCD harder to identify and treat. The exact same is really true when a person with OCD struggles with sadness, substance abuse, or binge eating conditions. Signs of OCD are seen in association with some other neurological disorders. There is an increased rate of OCD in individuals with Tourette's syndrome, a disease identified by involuntary movements and vocalizations. Private investigators are presently studying the hypothesis that a hereditary relationship exists between OCD and the tic disorders. Other diseases that might be connected to OCD are trichotillomania, the repeated desire to pull out scalp hair, eyelashes, eyebrows, or other body hair, body dysmorphic disorder, excessive preoccupation with imaginary or overstated defects in appearance, and hypochondriasis, the fear of having, in spite of medical examination and reassurance, a pretty serious illness. Researchers are investigating the place of OCD within a spectrum of conditions that might share certain biological or mental bases. A typical misconception is that people are rather compulsive or perfectionist by nature can be categorized as having OCD. Many individuals who show some compulsive or obsessive tendencies, which may be 90% of the population anyhow, do not really show severe enough symptoms to be labeled as having a disorder in this sense. Furthermore, try to see the value and contribution of being obsessed with a tidy or organized environment or the tendency to flawless things. How many firms could work without their exact accountants? How many cosmetic surgeons would do a great job if hygiene was not one of their most important standards? And how many people would feel comfortable in a space where absolutely nothing was tidied up or organized? Compulsive habits have their place in society, and some of them are highly needed. The problem with the ones who have OCD relies on the interference with important reasoning and crucial everyday jobs. Someone's story. Someone with OCD said, "As far back as I can remember, my family and friends referred to me as a worrywart. When I was all about the age of 16, my experiences with OCD began. I had just begun high school and things were stressful with all of the changes. A friend of mine had been affected with a case of food poisoning, and that was when I obtained my fear of being poisoned. I can still remember how it started as a small concern and proceeded to snowball into the major preoccupation of my life." Brain science. OCD is actually brought on by a combination of biological, mental, and ecological components. As far as the biological elements are concerned, an absence of serotonin, as I discussed earlier, is the primary cause. Serotonin sends neurological messages that transmit signals between brain cells. It contributes in mood control, impulse control, aggressiveness, hunger, sleep, pain, and body temperature level. For example, after a seat to the restroom, you might start to clean your hands to remove any harmful germs you might have come across. When you have performed the proper behavior, in this case cleaning your hands, the impulse from this brain circuit diminishes and you stop washing your hands and set about your day. It has been suggested that if you have OCD, your brain has difficulty switching off or ignoring impulses from this circuit. This in turn means the fixations and compulsions continue, leading you to wash your hands again and again. Studies concerning the numerous specific parts in the brain show that people with OCD show more typical activity in 4 interconnected areas in the brain. 1. The caudate nucleus. 2. Specific brain cells in the basal ganglia. 3. The prefrontal orbital cortex. 4. The cingulate gyrus. The first, the caudate nucleus, is considered to be the main part of the brain that controls repetitive and regular behaviors. Medication to treat OCD helps diminish the activity in this part of the brain. The last one, the basal ganglia, functions as a filter of thoughts getting in the center of the brain from other parts. The prefrontal orbital cortex, located in the front area of the brain, is believed to make reasonable decisions and affect social conduct. In the brain of a person with OCD, there's too much activity not having in this area. Usually, the case is that this region has been harmed just because of biological or psychological incidents and developments. A lack of guilt or responsibility is usually a symptom of somebody who is addicted and lacks activity in this part of the brain. The balance is off. The people who have become addicted either to pornography, compounds, eating, or betting have a smaller-sized frontal cortex with insufficient activity. In the brain of an addict, the frontal cortex is too little. Nevertheless, in the brain of a person with OCD, there's way too much brain activity in the frontal cortex. What does that mean? It means that they often be too worried, extremely concerned, preoccupied, or left feeling too guilty or afraid to act wrongly. The last one, the cingulate gyrus, is situated in the center of the brain, just like the basal ganglia. The cingulate gyrus contributes emotional responses to obsessive ideas. The emotions linked to the compulsive behaviors are usually what makes an OCD patient stuck in her or his patterns. This region of the brain is also highly interconnected with the prefrontal orbital cortex and the basal ganglia through numerous brain cell paths. All of these neurological paths and areas are highly affected by the levels of serotonin in the brain. Genetic causes. As with a lot of disorders, OCD seems to run in the family. Approximately 50% of all cases with OCD show this pattern. If somebody has a family history with this disorder, he or she is more likely to have it, and siblings, parents, or children. Research studies have fought the presumption that members of the family teach OCD to one another, based on the observation that individual family members normally have different signs of OCD. Scientists could not find specific genes that cause OCD, so in this sense, the genetic roots are still rather of a secret to a lot of clinicians. There has, though, been a ton of discoveries regarding the regulating of serotonin. Studies on twins have suggested that if one twin has OCD, the other has more of a propensity to have the same disorder. Nerve cells. The job of your afferent neuron is to send out messages and interconnected impulses, kind of like a telephone wire. Nevertheless, nerves aren't single string. The cells are all linked to one another. It's like the game of telephone, where a person whispers something in a person's ear, who whispers it to the next, and so on. Eventually, the message changes, and in some cases, it entirely differs from what the original message was supposed to be. This is how the brain works as well. The messages and impulses go through a series of procedures and regions which divert the original message and turn it into a somewhat different interpretation. How different that interpretation is depends upon the person, how well the cells work, and on how healthy and undamaged those neurotransmitters inside a person's skull are. One nerve cell sends a message to another, and that one sends out the message to another, and each time an afferent neuron gets a message, a chemical gets released. Usually, these substances are serotonin. A crucial gene in this process is hCERT, and this makes serotonin transporters. At times, when a person has OCD, the hCERT gene works too rapidly, which triggers the cell to gather all the serotonin before the next cell has even gotten the signal. OCD patients' nerves are whispering when they are supposed to be yelling. Another reason for the disorder, according to research, might be the membrane protein accountable for the reuptake of serotonin from the synapse between the nerve cells. That transporter protein is bound by serotonin inhibitors, or SSRIs, which block the transporter's function and leave more serotonin available for neuronal communication within the synapse. The scientists found a mutation inside the hCERT gene, which they classified I425V. The anomaly seems to be associated with an extended expression of the hCERT gene, leading to extra transporter proteins appearing inside the nerve cell's membrane. That results in accelerated reuptake of serotonin in those neuronal synapses, lowering the amount of serotonin available inside the synapse for signaling. The second anomaly identified, a long allele of the promoter part of the serotonin transporter gene, 5-HTTLPR, outcomes in equivalent cellular results, a boost in transporter proteins resulting in a decline in serotonin being available for neuronal discussion. The two anomalies performing together bring about an especially lower amount of serotonin available within the synapse than is visible with either one of the mutations alone, resulting in additional biochemical consequences and more extreme symptoms and signs. Other research has revealed that there can be some of other elements that would contribute inside the beginning of OCD, like behavioral, cognitive, and ecological elements. Research has discovered a terrific offer about the mental aspects that preserve OCD, which in turn has produced efficient psychological treatment within the shape of cognitive behavioral therapy, CBT. An example would be the following. According to the learning theory, OCD signs and symptoms are a result of a person developing learned negative ideas and behavior styles in the direction of previously impartial conditions which can result from life research studies. Many cognitive theorists really believe that the ones with OCD have malfunctioning beliefs, and that it is their misinterpretation of invasive ideas that causes OCD. According to the cognitive model of OCD, all of us experience intrusive thoughts from time to time. Even so, human entities with OCD frequently have an inflated experience of duty and misread these ideas as being really essential and full size that could result in devastating outcomes. The repeated misconception of intrusive thoughts leads to the development of the obsessions, and because the thoughts are so distressing, the man or woman participates in compulsive behavior to try and withstand, block, or neutralize the obsessive thoughts. Several researchers trust that this concept questions the natural concept, as humans can be born with a natural predisposition to OCD but in no other way develop the full disorder, while others are born with the same predisposition but when subject to enough learning experiences develop OCD. Researchers have observed that another gene called SLC1A1 is most likely involved. This gene is similar to HSERT, but supervises of soaking up a completely different neurotransmitter described as glutamate. Psychological causes. So many mental theories have been delivered to give a clarification for the enhancement of OCD. The two that have received the greatest support are the behavior and cognitive theories. Chapter 5. The behavioral and cognitive theories. Behavioral theory. The behavior theory suggests that human beings with OCD associate certain things or circumstances with fear, and that they discover ways to stay away from the important things they worry about or to perform rituals that help lessen the concern. This pattern of stressing and avoidance ritual can also begin though people are under periods of excessive emotional pressure, together with beginning a brand new process or ending a relationship. At such times, we are more vulnerable to fear and tension. Typically, matters once regarded as neutral might also start to bring about feelings of concern. Here is an example. A person who has always had the ability to use public bathrooms may, when under pressure, make a connection between the restroom seat and a worry of catching an infection. Once a connection between a product and the sensation of concern becomes set up, human entities with OCD keep away from the matters they fear rather than face or tolerate the fear. For example, the person that fears catching an infection from public restrooms will keep away from using them. When forced to use a public bathroom, she or he will be able to perform troublesome cleaning rituals, which include cleaning the toilet seat, cleaning the door handles of the cubicle, or following a detailed washing process. As those actions quickly decrease the level of fear, the concern is never challenged and dealt with, and the behavior is enhanced. The association of worry could furthermore spread to other things. That includes public sinks and showers. In behavior therapy, individuals with OCD find ways to face and reduce their anxiety without working toward avoidance or ritual conduct. After they learn how to straight-face their fears, they be less afraid. Cognitive theory. While the behavioral concept concentrates on how humans with OCD make an association between an item and fear, the cognitive theory focuses on how people with OCD misread their thoughts. The majority of people have intrusive or unwelcome thoughts, just like the ones pronounced by way of human beings with OCD. As a circumstances, parents under pressure from looking after an infant can also have an intrusive notion of damaging the infant. Many people might be able to shake off this type of idea. Most people liable to developing OCD, however, might exaggerate the value of the idea and respond as if it represents a real hazard. They will think, "I must be a threat to children if I have thoughts of hurting kids." This could trigger a high level of madness and other bad feelings, along with disgrace, guilt, and disgust. Those who come to fear their personal thoughts typically try to neutralize feelings that arise from their ideas. One way this is done is by means of keeping away from conditions that may stimulate such ideas. Another way is through carrying out rituals together with washing or hoping. Cognitive concepts suggest that as long as people translate intrusive ideas as catastrophic and as long as they continue to really believe that such thinking holds truth, they could continue to be distressed and to exercise avoidance and/or ritual behaviors. In line with the cognitive theory, individuals who connect overstated risk to their thoughts do so because of fake ideal visions learned earlier in life. Researchers presume the following beliefs may be critical within the development and protection of obsessions. 1. Exaggerated responsibility, or the belief that one is responsible for stopping bad luck or damage to others. 2. The concept that positive ideas are extremely critical and should be managed. 3. The belief that somehow having an idea or an urge to do something will increase the possibilities that it will come to life. 4. The propensity to overestimate the likelihood of danger. 5. The perception that one must always be ideal and that mistakes are unacceptable. After I initially experienced my OCD, I thought I was losing my mind. I had by no means fretted about those ideas before, and now I was totally covered with them. I knew what I used to be feeling became unreasonable, but I still had this terrifying feeling of what if? What if it was at all feasible for this stuff to happen? I knew that the odds were 0.0001%, but I would still be overwhelmed with the worry that something dreadful would possibly strike me or somebody else. In cognitive treatment, people unlearn their incorrect beliefs and exchange their styles of thought. Through doing so, they have the ability to get rid of the anguish connected with such thoughts and to stop their compulsive habits. No person actually knows what different aspects might be concerned. Maybe an illness or maybe normal life tensions should lead to the activity of genes associated with the symptoms of OCD. Typically accepted inside the past, but nowadays increasingly more left out, the psychoanalytic theory shows that OCD develops just because of a person's fixation springing up from unconscious disputes or strong pain they experienced at the time of infancy or youth. This theory is now pretty appropriately neglected, just because of the failure of psychoanalytic treatment to deal with OCD. Significant stresses or irritating life activities could also precipitate the onset of OCD. Even so, those aren't thought to cause the OCD, but rather activate it in a person already inclined to the disorder. Sadness is also once in a while thought to cause OCD, in spite of the simple fact that the general opinion is split, with most experts believing that depression is normally a sign of OCD instead of a cause. There is, however, a great deal of theoretical contention surrounding the definitive cause of OCD. However, all of the above theories offer engaging and highly helpful insights, with the possibility that a mix of the theories might also become identified as the real reason for OCD. Whilst the cause is currently still being debated, in some cases intensely by the researchers, what isn't always in competition is the reality that obsessive-compulsive disorder is certainly a continual, but similarly a very treatable health condition. Chapter 6. Environment Causes of OCD. Ecological stress factors may be a cause for OCD in people. Let's have a look at some of these stress factors. Brain injuries in teens and children have also been connected to an increased risk of a continuing obsessive-compulsive disorder, with one research study finding that 30% of kids aged 6 to 18 who experienced a brain injury showed signs of OCD within 12 months of the damage. Normally, research suggests that sufferers with OCD often report traumatic and hard life circumstances before the disorder starts. Tension and parenting patterns are environmental elements that have been blamed for causing OCD, but no evidence is really there yet to that claim. Fine, these elements could add to the development of it, and the right environment for an OCD patient definitely figures out how strongly the signs appear. But to say that the environment or an individual's youth by itself are the main roots of obsessive-compulsive disorder is a false notion that cannot be proved. Pressure doesn't trigger OCD, in spite of the fact that a distressing event may also activate its start. If left unattended, routine anxiety and pressure in an individual's life will intensify symptoms and signs of OCD. Problems at school or paintings, college exam pressures, and regular issues in relationships can bring all contributory elements to growing the frequency and intensity of someone's OCD behavior. Several children begin to display signs after a severe infection, which could be something like strep throat. The frame's natural reaction to infection, the production of sure antibodies, though directed to parts of the mind, could be related in some way to pediatric autoimmune neuropsychiatric problems related to streptococcal contamination, PANDAS. Research realized that the infection doesn't primarily trigger OCD, but it sets off signs and symptoms in children who are genetically inclined to the disorder. It is far idea that if OCD is caused by a kind of strep throat, the signs will start quickly, in all probability within a couple of weeks. Chapter 7. Some solutions. Now we're going to go over a few solutions. Left untreated, OCD generally develops into a persistent condition with episodes where symptoms appear to enhance. Treatment for OCD will depend upon how a lot the circumstances influence the patient's ability to operate. The best treatments. First-line treatments for OCD will regularly include 1. CBT, cognitive behavioral therapy. 2. SSRI, selective serotonin reuptake inhibitors. 3. Mix of SSRI plus CBT. 4. Cognitive behavioral therapy. CBT is an effective method of dealing with OCD. CBT is a sort of psychotherapy, talking treatment, that tries to help the patient change the manner they actually believe, feel, and behave, and refers to two incredible treatments: an exposure and reaction avoidance, ERP. B. Cognitive treatment. Research studies have revealed that 75% of human beings with OCD are considerably helped through cognitive behavior therapy. Exposure and response avoidance, ERP. Direct exposure. A part of this solution entails exposure to conditions and items that cause fear and anxiety. Over the years, the tension generated through those obsessional signals decreases, and subsequently the obsessional signals cause little or no anxiety. Response. Reaction avoidance describes the ritual habits that people with OCD have interaction in to minimize tension. This treatment makes it possible for patients to learn how to face up to the urge to carry out those routines. Here are some tips for dealing with OCD, just to line them up. 1. Continually count on surprises. You can have an obsessive thought at any time or in any area. Do not be surprised if some new ones happen. Don't enable it disturb you. 2. Be inclined to just accept hazards. Danger is a crucial part of life, and as such it can't be entirely gotten rid of or overlooked. Consider that not recuperating is the biggest hazard of all. 3. Do not lose time seeking to save yourself. This might only have the opposite effect and result in having even worse thoughts. Research studies have indicated that you cannot effectively prevent or reduce ideas, so accept that. However, a thought is a thought, absolutely nothing more. 4. Don't get restless with your progress. Don't compare yourself to other individuals. Everyone has their own pace. You can just concentrate on doing your treatment homework each day, one day at a time. 5. Face the anxiety. Don't hesitate and try to avert it. The best way to get rid of fear is to understand it is there. You can't switch off your ideas, so just face them. It is the only roadway to healing. Choose the harder one when challenged with two decisions. 6. Look at your homework from treatment every day. It's simple to overlook your tasks, specifically the ones you don't want to do. 7. Let your therapist know about tasks that are too hard for you. If you can't do it, then do not. You are not prepared yet, and that's fine. The homework they give you is not supposed to overwhelm you, but help you. 8. Don't postpone treatment. There is no flawless moment. The flawless moment is just when you start acting. Perfectionism is something you are trying to stay away from anyway, since it lies at the root of obsessive-compulsive disorder. Don't be too hard on yourself and just do what you can. Don't do your homework so exceedingly that it takes too much time. Living life to the fullest is the purpose. So get rid of that one-track mind towards your objective for a little bit and enjoy the fun in your daily life. 9. Have faith in the homework you've been given. Do not brush it aside and only do it since you are asked to. If you don't trust your therapist, then what's the point? Appearance. These qualified professionals usually know exactly what they're doing and what you are supposed to do to get rid of or manage your disorder. So take their word for it and put your heart and soul into your projects. 10. It's all right to feel anxiety. After a while, it will decrease if you keep doing what you should be doing. So do not freak out about going crazy. Don't get mad since you're mad, and do not get stressed out as you are and you shouldn't be. I have been in those circles myself, and it's not worth it. 11. Don't forget that you still have OCD. That means you can't always trust your own emotions or reactions, because your brain has been wired to think in extremes. If you don't know for sure if something is a sign, then treat it as one. It's better to do a little more than insufficient. 12. Remember that compulsions are the problem, not anxiety. If you recognize this, you will stop the compulsions and stay with the fearful situation. Ultimately, the anxiety will go away as you boost your tolerance levels. 13. Reward yourself. It does not need to be a physical benefit. It can be just patting yourself on the back or be proud of yourself. Look back at the recent projects that are no longer difficult if you think you aren't making good enough development. 14. Bear in mind that OCD is paradoxical and doesn't always add up. It does not make sense what you feel all of the time. Some things appear even worse than they are, so do not go crazy and relax as much as you are very capable of. Medication, counseling, and treatment. Let's talk about some options to the disorder. First of all, let's continue with medicine, since I already pointed out some facts about this. Medicine. Corrective medications called particular serotonin retakeup inhibitors, SSRIs, are typically used to handle obsessive-compulsive disorder, though it is not totally perceived why the SSRI solutions appear to help a couple of individuals with OCD. There is a certain medication that withdraws OCD by gathering serotonin by means of transporters such as HSERT, which mentions that serotonin stays inside the range between the cells longer and increases the odds that the second versatile gets the message, which spare you some OCD signs and bad effects. Therapy. Medical trials just recently have shown that medications that impact the neurotransmitter serotonin can overall diminish the manifestations of OCD. The first of these serotonin retakeup inhibitors, SRIs, particularly verified for the usage in the treatment of OCD, was the tricyclic upper clomipramine and anafranil. It was routed by different SRIs that are called particular serotonin retakeup inhibitors, SSRIs. Those that have been verified by the Sustenance and Medication Organization for the treatment of OCD are citalopram, Celexa, fluoxetine, Prozac, fluvoxamine, Luvox, paroxetine, Paxil, and sertraline, Zoloft. Extensive evaluations have confirmed that more than 75 out of 100 clients are helped by these pharmaceuticals. What's more, in the majority of patients, solutions reduce bad side effects of OCD by reducing the reoccurrence and power of the fixations and impulses. For clients who are just in part receptive to these medicines, research is being directed on the usage of a SRI as the necessary pharmaceutical and one of a selection of prescriptions as an extra medication, an augmenter. Drugs are of support in controlling the side effects of OCD. Conduct treatment. Psychological behavior treatment, CBT, has seemed the best sort of psychological therapy for this problem. The patient is presented to a scenario that activates the over-the-top signs and adapts step by step to endure the stress and fight the temptation to play out the impulse. Prescription and CBT together are thought to be superior to treatment alone at reducing side effects. Certain approaches demand that the patient deliberately stands up to the dreaded demonstration or idea, either particularly or by creative capability. In the meantime, the patient is unquestionably urged to forego ritualizing, with support and structure given by the professional and maybe by others whom the patient volunteers for help. Treatment then continues on a well-ordered premise, guided by the patient's capacity to endure the agitation and control the ceremonies. As treatment advances, most patients gradually encounter less anxiety from their excessive thought patterns and can oppose their impulsive dispositions. Psychotherapy can also be utilized to offer powerful approaches for lessening stress, tension, and settling inward clashes. Approaches to make treatment more effective. Stretch administration systems and consideration can help people with anxiety problems relax themselves, and so they might upgrade the impacts of treatment. There is evidence that vigorous practice may have a quieting impact, since caffeine, certain illegal medications, and even some other pharmaceuticals can disrupt the signs of anxiety issues. They ought to be avoided them. To put it simply, do not do drugs or any medication the doctors haven't prescribed. And don't use caffeine. Talk to your medical professional or drug professional before taking any extra medications. Family. The family is vital in the recuperation of someone with an uneasiness issue. In an ideal world, the family ought to be strong but not help support their valued one's bad effects. Family members ought not to trivialize the chaos or request change without treatment. At the point when a relative experience happens, it works to be understanding about their advance and recognize any triumphs. When a family is encouraging of an individual with OCD and lionizes and empathy, clients will be less restless and better able to handle the results of their disorder. While this is obvious, reality shows that tons of relatives undervalue the impact they can have. This has been OCD. Background, Solutions, and Symptoms for Patients. Written by Sid Van Roy. Narrated by Doug Green.